Last we talked about, we were discussing end tidal. End tidal has to do with the capnography or the CO2 that the body's producing. So we're going to talk about manual airway maneuvers right now, and whenever we run through our CAB, our ABPU, if we come up on a patient and they're not alert and we're feeling their circulation, okay, they have a pulse, now we're adjusting breathing. Maybe they're not breathing. First thing we want to do is open the airway. A lot of times the patient's tongue can get in their way. And we'll hear snoring respirations if this is the case, so we'll use things like the jaw thrust and head tilt, chin lift. So like patient laying like this on the ground, tilt back and lift the chin while you tilt the head back, head tilt, chin lift, obviously. Jaw thrust is for if you can't do the head tilt chin lift, and also the patient is in C-spine maneuver. So you will use your fingers, your thumbs to press up the jaw. Yep, head tilt chin lift, we did that. Let's make this bigger. I might be missing something here. With the patient in supine position, you know what, no I'm not, this is boring. Let's get to the good stuff. How are there so many slides on this? Tongue jaw lift maneuver. More commonly open a patient's airway for the purpose of suctioning or inserting an oropharyngeal airway. Pharyngeal, throat or air? I can't remember what the Greek word for that is. I'm pretty sure it's air. Cannot be used to ventilate a patient because it will not allow for an inadequate mask on the seal of a patient's face. So that is good to know. So it's not going to allow adequate seal for BVMing. Position yourself on the side, place the hand and close the patient's forehead. Really, if you're not watching it, then it's kind of a pain. Let's see, this might look interesting. Use your first knuckle under the incisors or gum line while holding the patient's head, maintaining the hand. Yeah, it's hard to even like read and not visualize or be able to visualize. All right, suctioning. So if it fills with vomitous blood secretions, the suctioning apparatus enables you to remove material quickly and efficiently. Ventilating the patient, they might have secretions in their mouths, and it is going to force material into the lungs to aspirate. We do not want that. That will kill the patient. Clearing the airway with suction indicated that you hear gurgling is your next priority, so open the airway with a manual maneuver. Suctioning equipment, we have the hand-operated one, which sucks. And then we also have the Yankauer. I think this is called the Yankauer. Maybe the whole thing is called the Yankauer. And then this is the nice one with the battery power that does it all for you. This one does too. It's just, this one is mobile. You can carry this out of the ambulance. Yeah, the fixed suction unit, the portable suction unit. Regardless of your location, you must have quick access to suction should you need it. Know where it's at in your airway bag. Don't get caught with your pants down. If you're looking for it and somebody's aspirating, that is on you. Mechanical or vacuum powered suction units, so should be capable of generating 300 millimeters Hg within 4 seconds of clamping off the tubing. Amount of suction should be adjustable, and we want to check the vacuum on the mechanism suction unit at the beginning of every shift. So we want to flick that on. I didn't do that yesterday, shame on me. Going to do that now. Turn on the device, clamp the tubing, make sure that the pressure gauge reads 300 millimeters Hg. Ensure that all battery charged units have fully charged batteries. Obvious stuff, but it will bite you in the ass if you don't do it. So this table shows the common devices. We have the hand powered. It is lightweight, inexpensive. You could leave it with the patient if you wanted to. Limited volume. These are disadvantages. So body fluid contact, honestly, it's just terrible. Yeah. Then you have the oxygen-powered portable. Not even sure what that is, actually. Lightweight, small, has limited suction power, uses a lot of oxygen for limited suctioning power. The battery-operated, it is lightweight, portable, excellent suctioning power. Most problems can be identified and fixed in the field. More complicated mechanics may lose battery integrity over time. I'm just kind of reading these to you. I'm looking for anything that stands out. It might be in the test. Extremely strong, adjustable vacuum power. Components are disposable. Yeah, I don't know if this is relevant or not. The following supplies should be readily available: wide bore, thick walled, non-linking tubing, soft, rigid suction catheters for babies, non-breakable disposable suction bottles, supply water for rinsing the catheter. Yeah, so know where all of that is at. So, like if you're in the back of the rescue, just role play through a scene, a situation, and grab a notepad or whatever. Pretend like this is happening right now. And this is if you're by yourself. If you have someone that's done this before, I honestly have very limited suction. Not credibility. What am I thinking of? Experience. I haven't really done it a lot, like very minusculely. So someone that has, run through a scenario with them, like what happened, what went wrong, what could have been better, what could have happened faster. Yeah. Suction catheter, hollow cylindrical device used to remove fluid and secretions from the patient's airway. The Yankauer catheter, tonsil tip catheter. This is your Yankauer. This is your French tip. So the Yankauer is a good option for suctioning the pharynx in the adults. Preferred device for infants and children, plastic tip catheters with a large diameter, rigid so they do not collapse, and capable of suctioning large volume of suction rapidly. Tips with a curved contour allow for easy rapid placement in the oropharynx. Soft, plastic, non-rigid catheters, sometimes called French or whistle tip catheters, can be placed on the oropharynx or nasopharynx, so you can actually stick it in the nose should you choose to. You can also go down an endotracheal tube if you have intubated already. Comes in various sizes, and you have smaller diameters than rigid catheters. Used to suction the nose, suction liquid secretions in the back of the mouth. Situations which the rigid catheter cannot be used, and suction the attached to facilitate suctioning of large debris in the oropharynx and allow access to the back of the pharynx. Side note, if somebody has something that's like loose but can like water seal in a way, I'm trying to think of an example, I guess like a peach, right? You don't have to suction the peach. You're not going to get it down there. But what you can do, you use that suction to get a grip on it, pull it with the least amount of resistance, and pull the peach out of the patient's throat, if that's what you're sucking. So it doesn't have to just suck it down the tube. Use it to get a grip on it. And if you need to, pull from this side. Okay, that didn't work. Pull from that side. Use your head in that game. Suctioning techniques. So suctioning removes oxygen from the airway. Adequate pre-oxygenate is required before suctioning. We want to make sure that the patient has good perfusion, body is working as much as it can, and to do that we will use our pulse ox. We stick that on, wait till we get to hopefully, I guess 100 in this case, so pre-oxygenate, and it's okay to hit 100. As soon as you hit it, fire away and start suctioning. And we will do a limit of 15 seconds on adults, 10 seconds in children, 5 seconds in infants. Remember, infants breathe at a rate of like 36 breaths per minute, and each little breath that you're taking away, that matters. Do not stimulate the back of the throat because the vagal stimulus can cause the pulse rate to drop. After suctioning, continue ventilation and oxygenation. Soft tip catheters, these must be lubricated when suctioning the nasopharynx. Best used when passed through an ET tube. Suctioning is applied during the extraction of the catheter to clear the airway. After suctioning, reevaluate the patency of the airway and continue to ventilate and oxygenate as needed. Before inserting the suction catheter, measure for the proper size. I think this is on the test. So from the corner of the mouth to the earlobe. Here's the earlobe, corner of the mouth. That is how you get the proper size. Never insert a catheter past the base of the tongue. Technique, turn on the assembled suction unit. I feel like we don't need to do this. Airway adjuncts. Artificial help, okay. Airway adjuncts are needed to maintain airway patency in unresponsive patients after manually opening the airway suction. Not a substitute for proper head positioning, and after the airway adjuncts has been inserted, the appropriate manual position of the head must be maintained. So we have our oropharyngeal airway. This is how we keep them from choking on their tongue. If they have a gag reflex, they're going to vomit all over you. Curved, hard plastic device that fits over the back of the tongue. Makes it easier to ventilate patients with a bag valve mask. Can also serve as an effective bite block if they're having a seizure. Also, should be prompted in an unresponsive patients who have no gag reflex. Will stimulate gagging and retching in a responsive patient. To assess the gag reflex, use the eyelash reflex. I guess you brush your eyelashes across there. No, not really. If the patient gags during insertion, remove the device immediately and be prepared to suction. So this is how we size our oropharyngeal airway, OPA for short. So corner of the mouth, earlobe, same as your suction. Considerations, we want to know if they're unresponsive, contraindications, responsive patients, patients with a gag reflex, advantages, non-invasive, easily placed, prevents the block of the glottis by the tongue, disadvantages, no prevention of aspiration. So that's the difference between the ET tube is the most invasive, but also gives the most protection. They're not going to aspirate 99 times out of 100. Disadvantages, there's no prevention of aspiration. Complication, unexpected gag may cause vomiting. Improper technique can cause pharyngeal and dental trauma, so we don't want to beat the teeth up. If the oral airway is improperly sized or inserted incorrectly, it could push the tongue back into the pharynx, creating an airway obstruction. Rough insertion could injure the hard palate, that is the top, the bony part of the top of the mouth. I want to see what palate means in Greek. Before insertion, suction, yes. Technique, select an oral airway, that is the correct size. Open the patient's mouth. Okay, I guess this is relevant. So we're going to open the mouth. We're going to cross finger technique of the tongue and jaw, so kind of like so. And then we're going to take our OPA and we are going to stick it in facing up towards the roof of the mouth, the curved part, right? We want the okay, so if it's concave, right? We want the concave portion of it facing the top. If it was like a cereal bowl, we want the bowl facing the top. Then once we go in, we rotate 180 degrees so it faces the down and holds the tongue. You can't just shove it straight in. Use the tongue blade to depress the tongue, ensuring that the tongue remains forward, and insert the oropharyngeal airway with the tip pointed down. Yes. Curvature. That's the word I should have said. Curvature. Narrow nasopharyngeal airway. All right, so it's a soft rubber tube. It's inserted into the nose, into the posterior pharynx. Post means rear. Allow passage of air from the nose to the lower airway. So just going back, the posterior pharynx, right? You have two. You have your anterior pharynx that's here, and then you have the posterior because the nose goes behind your mouth, the inside of your mouth. Goes behind it to go down to your esophagus where you breathe. Range from size of 12 French to 32 French. Length depends on size. Do not use with trauma patients. So this is probably a test question. To the nose if you suspect a skull fracture. So a patient could have three different, I wonder if there's four. No, there's three. There's Fortis, I remember these. So going to trauma chapter, you have Fortis 1, Fortis 2, and Fortis 3. Fortis 1 would be, trying to remember. I want to say it's more than just your mandible. Like if this was broken off, that's not Fortis. But if you broke it, like if you had a mustache and it broke across, then that'd be Fortis 1. If it kind of split from the nose, then you'd have Fortis 2, and then above your nose basically would be Fortis 3. And Fortis 3 would be the most the worst one basically. I mean they're all bad. But anyway, if you have any of those or you have suspected trauma, we're not going to shove that in the nose because you potentially could just stick it into their brain and that's not going to help them at all. Must be inserted gently to avoid precipitating epitaxis, nosebleed. Taxis means arrangement. Epi is on the outside. Taxis, I think taxis means arrangement. I'm trying to think what that has to do with epitaxis of nosebleed. Oh well. Lubricate and that's Greek. Lubricate the airway generously with water-soluble gel. Preferably it contains a local anesthetic, so it doesn't hurt as much. Slide, it doesn't bother them as much. Slide it gently downward into one nostril. If you meet resistance, try the other nostril. One's bigger than the other. I want to say the right one. You go for the right one first because it's bigger. The nasal airway is too long, then it may obstruct the patient's airway. If the patient becomes intolerant of the nasal airway, remove it from the nasal passage. Have suction ready available. Does this say which one? No. But one of our nostrils, I believe, is bigger than the other. Especially if the patient's been doing coke, then shoot for that nostril because that thing is wide open. Considerations, indications, unresponsive patients with an altered mental status who have intact gag reflex. Contraindications, patient intolerance, presence of facial, specifically the nose. How long have I been going? All right. Presence of facial, specifically the nose, fractures of the skull fracture. Advantages, can be suctioned all the way through, and patients need a patent airway. Can also be controlled with unresponsive patients, can be safely placed blindly. No requirements for the mouth to be open if this is the case. Disadvantages, improper technique could make severe bleeding resulting in epistaxis, and that's hard to control. And that's, especially if they're unconscious, you definitely do not want that. Do not protect from aspirations either. Okay, maybe this will say. Select the nasal airway for the correct size, nostril, earlobe. Yep, so nostril to earlobe, just like everything else. Oh no, nostril. So nostril. There's no picture. Insert the pre-lubricated with the bevel facing the septum until the flange rests on the patient's nostril. So here we go. Looks like he's going for the left one first. So that's how you measure it. And in this case, his left one is larger. Airway obstructions. Paramedics recognize the signs of obstructed airways immediately and take corrective action. So sudden foreign body airway obstruction usually occurs during a meal in an adult, while eating or playing with a small toy in the case of children, and a multitude of other causes. So you have the tongue, laryngeal edema, you have laryngospasms, trauma, aspirations, and when obstruction is due to infection, severe allergic reaction, repeated attempts to clear the airway will be unsuccessful and potentially harmful. Requires specific management and prompts for the appropriate medical facility. Tongue, with altered LOC, tongue can tend to fall back, posterior wall of the pharynx, closing off the airway. With partial tongue obstruction, patient will have snoring respirations. With complete obstruction and no respirations, simple, correct to use the manual maneuver. This is the head tilt, chin lift maneuver. Foreign body could cause many deaths, often from food, choking on food. You have the typical victim, middle-aged or older, wears dentures, they could choke on their dentures, has consumed alcohol, depresses protective reflexes. So it's going to depress, I was going to say the sympathetic, but I think it just overall depresses your nervous system. Adversely affects judgment about the size of pieces of food. Increased risk with conditions that decrease airway reflex, such as stroke. Obstructions may be mild or severely depending on the object's size and location. Signs may include choking, gagging, stridor, dyspnea, aphonia. Haven't heard that word, aphonia. The ability to speak. So think of phonics, right? Aphonia. Dysphonia, difficulty in speaking. So that's another, hold on, this is, oh, that's pretty cool. Treatment depends on whether the patient is effectively moving air. Okay, so choking, gagging, stridor. Stridor in the case of there's a toy marble lodged right here. Also note, if the patient has had surgery on their throat at any point in time, I mean, this is a real life example that happened actually, not even whenever I was a medic, but they could chew steak and it gets caught on scar tissue from previous surgery or something else, or maybe it's not shaped naturally, it's been altered. Laryngeal spasms and edema. Laryngeal spasms result in the spasmodic closure of the vocal cords, completely occluding the airway. Often caused by trauma during an overly aggressive intubation attempt. Oof. Interesting. Overly aggressive intubation attempts. So I guess be as quick and smooth with intubation as you can be. Occurs immediately on extubation, laryngeal spasms, and edema. Laryngeal edema can cause the glottic opening to become extremely narrow or totally closed. Common causes include epiglottis, anaphylaxis, and inhalation injuries, such as smoke, running from a burning building. Breathing in that smoke is going to cause it to swell up. Anaphylaxis, that could be allergies, epiglottitis, croup. What's the other one? Streptococcus. Strep throat that turns into something else. No, that's when it, so your strep throat can actually affect your heart and cause ischemia. But I forget what the word for that is. May be relieved by aggressive ventilation or a forceful upward pull of the jaw. Muscle relaxant medications may be effective at relieving laryngospasms. Resolution does not mean laryngospasm will not reoccur. Transport the patient to the hospital for evaluation if this is the case. I'm going on 20 minutes. I feel I'm on fire. Fracture of the larynx increases airway resistance by decreasing the airway size due to decreased muscle tone. What is this? There's no info up here. Decreasing the muscle tone, laryngeal edema. So there's going to be swelling fluid around in the cells of the larynx. Larynx. Ventilatory efforts. Fracture of the larynx increases airway resistance. Yeah, due to ventilatory effort. Penetrating crush injuries to the larynx. This was on the test. There was something about a crush injury. So it was a lady who was ejected out the front windshield, I believe, and suffered from crush injury to the larynx. I'm not sure if that was the question or that was one of the answers, but it was something about crushed larynx, so everything in the slide is relevant. Advanced airway management may be required. I'm just going to go through it again. Laryngeal injury. So fracture to the larynx increases airway resistance by decreasing the airway size due to decreased muscle tone. Laryngeal edema, ventilatory effort. Penetrating injuries to the larynx compromise the airway secondary to swelling and bleeding. Aspiration could increase mortality, potentially obstruct the airway, destroys the delicate bronchiolar tissue. Bronchioles, that is in the lungs. The big tube, once it goes past your epiglottis. Destroys delicate bronchiolar tissue, induces pathogens into the lungs. So this is why it's so bad for aspirations. Now that there's pathogens that are in there, there's outside bacteria, like on my hand right now, just being in my pocket, probably, I don't know, like 10,000 different bacteria or viruses or whatever. Now all of that just got into the lung because it's open. So same as if in your stomach, bile, that can get in there. Spit, anything, whatever you're eating could also cause aspiration. And also it just obstructs in general. Suction should be readily available for any patient who is unable to maintain his or her own airway. Always assume that the patient has a full stomach, every time. That's why we don't want to ventilate too fast. We want to go slow, and we want to make sure that we're going into the lungs. Differences in management of mild versus severe airway obstruction are significant. So you have mild obstruction. The patient is responsive, able to exchange air, but show varying degrees of respiratory distress. We had an old lady that swallowed rice the wrong way and then hawked it up. Will usually have noisy respirations and may be coughing. Should be left alone. Let them do their thing. Let the body keep doing it. You're there if it gets worse. Forceful cough is the most effective means of dislodging the obstruction. Attempt to manually remove the object is to force it further down the airway. So yeah, don't touch it yet. Closely monitor the patient's conditions. Be prepared to intervene if you see severe airway obstruction. If it is severe airway obstruction, we have any of these. Cough is weak inspiratory stridor, cyanosis, may begin to turn cyanotic, may be frantic and exaggerated attempts to move air. And they may grasp their throat, universal sign for choking. That's a big one. Emergency medical care for foreign body airway obstruction. If the patient is responsive, ask, are you choking? If they nod yes and cannot speak, hold on, if this is relevant. I'm going to say no. Abdominal thrust, okay, so yeah, if you're going to do the Heimlich maneuver, then you want to do the most effective way to dislodge an object. Of course, once they are no longer making noise in their body, right? Not noise, yeah. If they're not making noise, they're not productively coughing, there's no air movement, that's when we move to the Heimlich maneuver. So you're going to make a fist, like so, and you're going like a J maneuver. So you're going in and up, in and up. Go in first, up, right? Squeeze up, like that. But like down here, you want it to be right where their diaphragm, underneath the diaphragm, where the stomach is. If patient is in advanced stages of pregnancy or morbidly obese, we're gonna do chest thrusts instead. So yeah, I mean, once they go unconscious, whether obese or pregnant or whatnot, you're gonna go to chest thrusts anyway, because eventually that will push the object out of the body. Do physics. If the patient becomes unresponsive position, there's the supine on the ground and begin chest compressions. Yes, just like I said. Now we're doing CPR. Open the airway and look in the mouth. Back to real life example. At this point, they may have a heart attack. You may do 30 compressions and you can't open the mouth. It's called trismus, and your body just goes into lockdown and locks your tightest muscle on your body, your jaw, locks shut, can't open it. And I couldn't get the piece of steak or even just open the mouth to see what was happening. If that happens, just keep doing compressions. That is the most that you can do until the jaw relaxes if paramedics come on scene. This is as anyone that's a bystander that doesn't have a box of drugs with them. Just keep doing compressions. If you don't know anything else about CPR, just do compressions as long as if they don't have a pulse. Because what you're doing, you're allowing that blood to move through the body, through the capillaries. At least it's not stagnant and it's not clotting and it's not stuck wherever it's stuck. It is doing, you could at least do that much to somebody. Attempt to remove the foreign body only if you can see it, you're not going digging, and attempt to rescue breathe. If the first breath does not produce visible chest rise, open the airway and attempt to ventilate. If both breaths fail, produce a visible chest rise, continue chest compressions. These are McGill's. They're good for laryngoscopy. Proceed with direct. If this technique does not work, proceed with laryngoscopy. Is it scopy? How do you say this? Insert the laryngoscope blade into the patient's mouth, and if you see a foreign body, remove it with McGill forceps. Laryngoscope. That's what we intubate with. Supplemental oxygen therapy. Supplemental oxygen should be administered to any patient with potential hypoxia. I'm thinking of that test question now. The one with the larynge crush injury. Indication of supplemental oxygen. We are going to, patients that get this are patients with respiratory distress, those with suspected, document hypoxemia, and saturation level less than 94%. As determined, EMS systems protocols, oxygen delivery method must be appropriate for the patient's ventilatory status, reassess frequently, and adjust based on clinical condition and breathing adequacy. We're going to stop there.